This is healthcare finance, where every visit is a workflow, every claim is a journey, and every dollar is governed by rules. Today, we're unpacking it all. 2 patients, same emergency room, same doctor, same diagnosis. One bill, $2,100. The other, $9,300. The only difference? The card in their wallet. This isn't a billing error. It's not a mistake. It's the system working exactly as designed. And today we're going to break it apart, piece by piece. Every hospital operates with something called a chargemaster, a master list of prices for every service, procedure, and supply. A box of gloves, $47. An aspirin, $15. These are not real prices. They are opening bids. Every major insurer sends a team to negotiate directly with each hospital. Thousands of line items. Both sides push. Eventually, they settle on a contracted rate, a number specific to that insurer, at that hospital, kept confidential for years. Medicare sets the baseline. For most procedures, Medicare pays around 100 cents on the dollar of its own fee schedule. Medicaid typically pays 80 to 90% of Medicare. Commercial insurance? Anywhere from 143 to over 358%. Until January 2021, these negotiated rates were completely secret. Both sides signed non-disclosure agreements. Your insurer didn't want you comparing. The hospital didn't want competitors seeing their deals. Patients had no idea what the system was charging in their name. In January 2021, CMS mandated that every hospital publish its negotiated rates online in machine-readable files. Researchers immediately started pulling the data. What they found confirmed what patients had suspected for decades. Rand Corporation pulled data from 4,000 hospitals. For a hip replacement at the same hospital, one insurer paid $18,000. Another paid $72,000. Same surgeon, same facility, same implant. A 4-to-1 price gap, not between hospitals. Within the same hospital. The reason is market power. United Healthcare covers 70 million Americans. When they walk into a hospital negotiation, the hospital cannot afford to lose them. A regional insurer covering 400,000 members has almost no leverage. The hospital knows they'll agree to almost anything. And here's where it gets personal. If your plan has a high deductible, $3,000, $6,000, or more, you pay 100% of your bills until you hit that number. You don't just pay a percentage. You pay the full contracted rate, dollar for dollar, out of your own account. Let's run the numbers. ER visit. Laceration. 7 stitches. Hospital chargemaster price, $1,400. Your Blue Shield contracted rate, $800. Urine deductible, you owe $800. Your colleague's Cigna plan, contracted rate $1,150. She owes $1,150. Same stitches, $350 difference. Multiplied across a year. Think of insurance plans as 3 pricing tiers. Tier 1, large national employer plans, the steepest discounts. Tier 2, mid-size plans, moderate rates. Tier 3, individual marketplace plans, small group plans, rates closest to the chargemaster. Same hospital, 3 different prices. Here's a wrinkle. Most large employers, Fortune 500 companies, self-insure. They set aside their own money to pay claims. They hire a third-party administrator just to process paperwork. They negotiate rates directly, and they often achieve better deals than traditional insurance. Now add another variable. The ER physician who treats you might not be employed by the hospital. She might work for a separate staffing company that never negotiated a contract with your insurer. You walked into an in-network hospital and got an out-of-network doctor. A KFF study found that before 2022, 16% of in-network ER visits included at least one out-of-network charge. In Texas, it was 38%. In New York, 33%. Patients who did everything right, chose an in-network hospital, still got surprise bills. In January 2022, the No Surprises Act went into effect. For emergency services, you cannot be billed more than your in-network cost sharing, even if every doctor who treated you is out-of-network. The law capped what providers can collect directly from patients. But the protection has limits. Non-emergency procedures scheduled during an ER admission aren't always covered. Air ambulance billing, partially covered. Follow-up services, case by case. The law is a floor, not a ceiling. And enforcement requires patients to know their rights. After every ER visit, Your insurer sends you an explanation of benefits, the EOB. It shows the billed amount, the contracted rate, what insurance paid, and what you owe. Reading it line by line tells you exactly which pricing tier you're in and whether any charges are wrong. Here's the full journey of your bill. ER visit happens. Hospital generates a claim, a coded record of every service provided. They submit it electronically to your insurer. The insurer's adjudication system applies your contracted rate and benefit structure. Result: your EOB and your bill. Before the claim goes out, a medical coder reviews your chart and assigns codes. CPT codes for procedures. ICD-10 codes for diagnoses. These codes determine everything about your bill. A more severe diagnosis code means a higher facility fee level and a higher charge. Every ER visit gets classified at one of 5 evaluation and management levels. Level 1, minor complaint, maybe $300 facility fee. Level 5, critical, life-threatening, anywhere from $2,500 to over $4,000. Just the facility fee, before any labs, imaging, or procedures. Here's the hospital's side. Their fixed costs, staff, equipment, facilities, don't scale down when a patient is uninsured. Medicare and Medicaid reimbursements frequently don't cover actual costs. Commercial insurance is where hospitals make up the gap. Hospital consolidation makes the pricing gap worse. When a health system acquires independent hospitals, the acquired hospital's negotiated rates often jump 40% or more, simply because the acquiring system has more bargaining power. Same hospital, higher rates. Within months. The RAND Corporation's 2023 hospital pricing report covered 4,000 hospitals and 3.9 million commercial claims. National average. Hospitals charge commercial insurers 254% of what Medicare would pay for the same service. That's not the outlier. That's the average. But that national average hides enormous variation. Wisconsin hospitals average 311% of Medicare. Maryland, which uses a unique all-payer rate-setting commission, comes in at 127%. Your state, your hospital market, and your specific insurer compound into your final number. Since 2021, price transparency files are public. For the same knee replacement at the same hospital, Anthem paid $18,600. Cigna paid $22,400. Aetna paid $27,800. United paid $31,500. These are not estimates. These are actual contracted rates, published by the hospital. You can use this. The RAND Hospital Pricing Transparency tool is free. Type in your hospital and your insurer. See your negotiated rates before you schedule anything. If you're facing a high-cost procedure, it's worth checking if switching to a different in-network facility saves $5,000. And if you've already received a surprise bill, appeal it. Request an itemized bill. Compare it to your EOB line by line. Look for unbundled charges, duplicate codes, services you don't recognize. Medical billing advocates report that a majority of detailed medical bills contain at least one error. Use transparency data at open enrollment. Before you pick your plan, look up the contracted rates for hospitals near you under each option. A $200 higher monthly premium might come with a 30% lower contracted rate at your local hospital, breaking even within 2 ER visits. 2 patients. Same room. Different bills. Now you know why. The system is complicated by design, but it has rules. It has rates. And it has rights you didn't know you had. Next episode. Observation status. Why being admitted to a hospital isn't always the same as being admitted. Follow the ER series.